Good morning, everybody. I'm really, really pleased and honored to chair this session. And also, I am really happy to talk about nutrition in this MASCC conference. So please take your breakfast. We are talking about nutrition, so don't worry. You can eat and take your breakfast, and let's talk in the next hour about nutrition. So we're going to talk about optimizing nutrition in oncology. We are two speakers. We are close friends that we have been working in clinical nutrition for so many years now, particularly in the cancer field. So it's an honor for me to share this session with you, but I would like to invite you to be part of the session, to discuss, take notes, ask questions, and we'll be really delighted to answer your questions and to discuss, to know what are your practices, and try to, of course, the idea is to feed correctly our cancer patients. So I'm Diana Cardenas. I am clinical nutrition physician, and I work at the Gustave Roussy Cancer Center at the nutrition unit in this center. So we are dealing every day with malnutrition. I would like to ask you a question. I would like to know if there is some dietitians in the room. 1, 2, 3, 4, 5. Good. There is a clinical nutrition physician. 1. Any nurse in nutrition practice? Or pharmacist in nutrition practice? Okay. So I hope you will enjoy this session. So we're going to have 2 lectures, about 20 minutes, and then we have time to discuss and to try to answer the questions. So I'm going to talk about nutritional foundation in cancer care. This is my disclosures, and I need to say that I have 2 main disclosures. The first is that I am ethics editor for the journals of the European Society of Clinical Nutrition, and I am also the coordinator of the International Working Group for the Patient's Right to Nutritional Care. And I need to confess that my only interest is to promote the access to nutritional care for all our patients. And I hope that at the end of this session, you will join us in defending this right, the right to access to nutritional care for all the patients. So I'm going to answer this very challenging question. What are the nutritional foundations in cancer care? Foundation means a basis upon which something stands or is supported. In other words, what supports why we need to feed our cancer patients. So we know, and of course you know, that every cancer patient with a cancer needs 2 types of treatments. On one hand, the disease-modifying therapies that aims to address the vulnerability of the tumor cells and have an impact on different standard endpoints, as for example, the overall survival. On the other hand, they need supportive care, that's why we are here. And supportive care addresses the integrity of the patient in a holistic way with an impact on the patient's reported outcomes, as for example, the quality of life. And at the intersection, we have nutritional care. Nutritional care should be considered, and I hope that at the end of my lecture you would agree with me, that nutritional care is a supportive care, but it's also a therapy that can modify standard endpoints. So I will show you this, during this lecture, I will give you examples of how with nutritional care we can impact survival and we can impact, of course, also quality of life. So what is nutritional care? Nutritional care is a process that should be provided in a systematic sequence that involves 4 steps. First of all, malnutrition risk screening. This means to identify patients at risk of becoming malnourished. This will lead to the assessment and diagnosis of disease-related malnutrition, or cachexia, if you want to name it like this. With, of course, this lead to writing up nutritional care plan and administering medical nutrition therapy, of course, on evidence. And of course, after this, we need to monitor and evaluate the effect of nutritional therapy. So the aim of nutritional care is to prevent and treat disease-related malnutrition and sarcopenia. So in order to answer this question, I proposed 3 aspects, 3 key points. First of all, reprogramming of energy metabolism. You know that this is a hallmark in cancer, And to understand the energy metabolism, it's important to know how to feed our patients. The second point I propose is evidence-based medical nutrition therapy, and I'm going to show you that there is more and more new evidence on how to feed the patients. And the last but not the least, nutritional care ethics. A malnourished patient is a very vulnerable person, and we need as healthcare professionals to respond in an ethical manner to this vulnerable person, and this is taking into account the cultural belief, the education, etc. So the first point I said is reprogramming of energy metabolism. This is a hallmark of cancer. And a hallmark of cancer is an acquired functional capabilities of almost at least every cell that allows cancer cells to survive, proliferate, and disseminate. And in the last year, 2 new hallmarks have been identified. One of these is the deregulation cellular of energetics. So this is the capability to modify or reprogram cellular metabolism in order to most effectively support neoplastic proliferation. And this adjustment of energy metabolism in order to fuel cell growth and division has an impact at the body level. This means that at the body level, literature showed that is around 50% of patients have an abnormal metabolism, and we in our unit, we practice inject calorimetry. And we know that around half of our patients have an abnormal metabolism with a trend to hypermetabolism. And this hypermetabolism is a direct effect of cell energy consumption because these adjustments of energy metabolism, but it's also an indirect effect or indirect panoplastic effect. So I'm going to show you some key elements of this hypermetabolism. We know that hypermetabolism is correlated with phenotype of malnutrition and biological markers. Some studies show that hypermetabolism status is an independent prognostic factor of survival and a predictor of early limiting toxicities in older patients with cancer. And normal metabolism in some types of cancer, as metastatic non-small cell lung cancer patients, we know that normal metabolism can be understood as a new independent parameter to identify patients who will benefit from immunotherapy. So we need to feed the patients, we need to provide enough and sufficient energy, of course, to treat and prevent malnutrition, but also because they will benefit better from new treatments. So this is results, so some example of some results of studies. This is studies in France from the group of Hôpital Cochin and Professor Golbasser, and they aim to investigate whether abnormal energetic metabolism could predict acute limiting toxicities of anti-cancer treatment. And they showed that metabolic alterations are an independent risk factor of toxicity with an odds ratio of 236. And what is very important is that it's an early marker. This means that patients are hypermetabolic, but they are not malnourished, and they don't have a systemic inflammatory response. So hypermetabolism can be an early marker. So hypermetabolism is also a caloric coverage. So the same team study aimed to investigate whether meeting calorie requirements improve the sensitivity to immunotherapy. And they showed that caloric coverage was independently associated with improved progression-free survival in hypermetabolic patients, and they conclude that energy supply is a critical determinant to the sensitivity to immunonutrition in some kind of patients. So we need to feed our patients in order to improve their nutritional status, but also to allow these patients to better accept their treatments. So we know that the alteration at the cellular level have an impact at the body level through different mechanisms. We had a lot of evidence of this mechanism, and it's very interesting because we can maybe explore targets to try to stop these effects. And mainly we have effects at the muscle level, reducing muscle strength and muscle mass, leading to sarcopenia. So how frequent this is, I will not say too much because my colleague Paula will say a lot more about this point. But we know in a French study, the Nutri-Cancer study, we know that around the prevalence of malnutrition is around 40%. We know, and very important, that the effect of weight loss and sarcopenia is on the response to chemotherapy, quality of life, and survival. So we really need to be aware of this. And the prevalence of malnutrition can vary among the diseases. This is also a result of this French study. And we know that, for example, esophagus and pancreas is one of the highest. And we know that this is important to know the difference of the prevalence between the different sites. But we know that from the same study that only few patients are being feeding adequately. Around half of the patients, 57.6% of the malnourished patients receive nutrition support, according to this French study. But we know, and we have also evidence for the Nutrition Day. I don't know if you know this Nutrition Day study. Someone in the room has participated in Nutrition Day? Please raise your hand. So please go. I had the website. Look for Nutrition Day. This is an ESPEN initiative. Nutrition Day is a worldwide multicentric study. In one day, you collect a lot of information of your patients. And this is more than 300,000 patients and 39,000 patients with cancer. So you have here in green patients without cancer, and in blue patients with cancers. And the prevalence is high. We know it's around 45% in cancer. But what is very interesting here, you can see here in the right side or left there, patients that are not eating nothing during the hospitalization. They are not receiving nutritional therapy. Only 31% are receiving enteral or parenteral nutrition, or 40% they are receiving oral nutritional supplements. So we know that the increase of resting energy expenditure and the decrease on food intake can lead to malnutrition and sarcopenia, with important impact on toxicity risk, quality of life, mortality, and cost. And we have the ESMO guidelines, and we had the ESPEN guidelines. They both agree on a lot of points, that they say that we need to tailor interventions. They agree also in the need to screen and assess correctly malnutrition, and they recommend to measure by intercalorimetry if we can, and otherwise to assume that to be similar to healthy subjects and ranging on 25 to 30 kilocalories per kilo per day, or if possible, up to 1.5 grams per kilo per day of protein. So these guidelines are trying to now be updated because we need and we have more and more new evidence. And how can we do this? How can we feed the patient? This is my second point. We need to feed evidence-based, or to practice evidence-based medical nutrition therapy. I mean with this slide that nutrition should be part of the whole journey of a patient with a cancer. The aim should be to maintain or improve food nutrient, of course, to mitigate metabolic derangement, to maintain skeletal muscle mass and physical performance, to reduce the risk of reduction of interruptions of scheduled anti-cancer treatment, and to impact, of course, as I said, on standard outcomes and PROS outcomes. So I'm going to show you some examples of this. Of course, we don't have time to approach everything, but I'm going to show you some clear evidence of strong papers that help us to feed our patients. This is a very recently published paper, 2 years ago. Last night I add this slide. This is from Ford and Carla Prado team. And this is, in this paper, this is a clinical trial with 2 groups, randomized clinical trial, and they tried to answer to this question: can we increase muscle mass in cancer patients? Because as I told you, and I'm sure Paula will explain you more of this, the importance of maintaining muscle mass and stimulate anabolism. And we can stimulate anabolism in our cancer patients. That is true. So they tried to ask this question, is that we can increase muscle mass in cancer patients. So there was an individualized nutrition counseling, positive impact over protein intake. So there were 2 groups. One group trying to, with only counseling, to go to 2 grams per kilo per day, or 1 gram. Of course, to get to 2 grams was very difficult, so there were interaction between both groups, but Despite this, they got really good conclusions, and they showed that over 1/2 of the patients in the 2 gram per kilo per day group maintain or gain muscle mass within the 12 weeks. So this work highlighted the potential for nutrition to attenuate muscle mass loss in patients with cancer. And this is an example that the role of dietitian is very important in clinical care. Oral nutrition supplements and dietary counseling is very important. There's a lot of evidence showing that oral nutrition intervention, supplementation, is effective at increasing nutritional intake, improving aspect of quality of life, etc. Dietary fiber, this is very important. This is a low-cost intervention with very, very high impact. And we know for this study, for example, there's a lot of studies, but this is also not a recent study, that showed that if you have sufficient dietary intake, you have an impact on progression-free survival. This is 128 patients with melanoma on immunotherapy, and they show a significantly improved progression-free survival. How about rehabilitation? I want to know if in your centers you have a program of rehabilitation. Please raise your hand if you have a program in your 1, 2, 3. Okay, so for the other people, please go back to your institutions and ask to create one rehabilitation program. Honestly, I need to say that rehabilitation is the key to improve quality of life, survival of cancer patients. Rehabilitation not only before surgery, but also before medical treatment. We need to reduce the impact of the treatment. We need to help to improve weight gain, muscle mass before the treatment starts, and then help them during treatment to maintain their muscle mass. You will see in your practice that your patient will feel better, and the impact and the process of the journey in this patient will be better. This is an example of how, and this is a randomized clinical trial, showing that rehabilitation is significantly improved functional capacity before and after surgery, but we have similar results with nutrition. I could not talk about the effort study of Philip Schultz in Switzerland. This is a very important study of nutritional support during hospital stays, reducing mortality in patients with different types of cancer. This is a secondary analysis of a prospective randomized trial. This is a protocol-guided, individualized nutritional support versus standard hospital food. And they were able to show, for the very first time in a very important amount of patients, that an early individualized nutrition support in patients with cancer and increased nutritional risk, reduce risk of mortality, improve function and quality of life outcomes. So this is very, very important. This is the figure showing the impact on mortality. So we can say that nutrition can help reduce mortality. And we have the evidence, of course. The effect of immunonutrition on cancer patients undergoing surgery. There is good evidence. It's evaluated as moderate. Immunonutrition implies the use of some micronutrients, as for example, arginine, omega-3, and the use of immunonutrition in patients who have undergone oncological surgery decrease the level of inflammatory markers and infection post-operatory complications in almost all localizations. This is a systematic review that shows the same thing, the effect of immunonutrition in upper GI cancers in reducing the risk of infection complication about 30%. This is a very impact outcome. So if I ask you this question, can we improve cancer with nutrition? Who said yes? Somebody says no? Please, yes, of course. We need to know which outcome, and we need to know that it's not cancer. We are treating patients with a cancer. And that is why ethics is so important. Only a couple of slides more. I said that a malnourished patient is a very vulnerable patient. And as healthcare professionals, we need to respond in an ethical way. And that is why the principle of ethics and the principle of human rights can inform each other. I can guide us to help to feed adequately the patient. So the patient must be at the core of the care, and we need to respect the dignity. And that is why we are studying the human rights-based approach, And we said that the access to nutritional care is a human right. This means that the patient had the right to benefit from malnutrition, to be screened, to be diagnosed, and to receive medical nutritional therapy, of course, evidence-based medical nutritional therapy. And this human right is linked to two very well-known human rights, the right to food and the right to health. It's very important to understand that we are not saying that we need to feed every patient at the end of their life. On the contrary, we need to know when to stop. But we need to recognize that we need to promote the access to nutritional care for every single patient. So a couple of years ago, we signed in the ESPEN Congress in the city of Vienna. 75 clinical nutrition societies were able to sign this international declaration on the human right to nutritional care. And in this declaration, we said that the access to nutritional care is a human right, and we set principles, and I invite you to go and look for this declaration. It's in our website, in the website of the ESPEN societies, and in all the websites of the societies that have signed the declaration. And look and see these 10 principles, and you will agree with me that clinical nutrition is central to nutritional care in cancer. So, key messages to take home. The nutritional foundation in cancer care are metabolic, clinical, and ethical. And if somebody asks you if we can improve cancer with nutrition, please say, of course, yes. Thank you very much. Just a small message before leaving the floor to Paula is we're having a course in Paris. So I will be very welcome to receive you in Paris, in Gustave-Roussy, to learn with experts, to learn nutritional metabolic management of patients with neoplastic diseases. We will have 4 really nice days learning from the best experts in the world, I can say. And if you are interested, please send me an email. On just after the lecture, we can discuss if you are interested, and we will be really, really happy to have you in this course. So now, I would like to introduce you Paula. I think Paula is really a reference in the worldwide of nutrition. She has been studying nutritional care for so many years. Just some words is Professor Paula is an associate professor of medicine and nutrition in the Católica Medical School in Portugal, and at the Universidad Católica de Portugal he works at the Center for Interdisciplinary Research. So please, Paula.
Thank you so much for the lovely presentation. Thank you so much for the kind invitation to be here. It's a pleasure. And it's an honor. I think that there is a lot to be done, but I really think that we are willing to build something new with the collaboration of this Congress as well. So this is the theme that I was given to try to share with you some of the evidence that contextualizes the main problems that affects cancer patients, kind of wanting to design a roadmap for nutritional management in cancer care and in the oncology setting, and I will try to share the newest evidence that supports this. Indeed, just like Diana mentioned very well, we do have a major problem in terms of malnutrition, of undernutrition and cachexia in cancer patients. This is known for more than 30 years now. For more than 30 years, we have studies that show us this high prevalence and the magnitude of the problem, and the studies nowadays are simply confirmatory of what we have known for more than 30 years, which is kind of striking, I would say. We do know that the prevalence of cachexia in cancer is big, as you can see here by the prevalences shown in this paper by the team of Maurizio Muscaritoli, independently of the type of cancer that we are talking about, independently of the primary cancer site. We do know that if we have the disease in progression, if we have a progressive disease, more advanced disease stages, then the greater the problem is in terms of cachexia and in terms of malnutrition and undernutrition. This is one part of a PhD thesis from Carolina. These are data that we have published 2 years ago, showing real-life data in patients that were referred for the oncology department for chemotherapy as first-line treatment. What we have found, with a simple question just asking and assessing patients if they had lost weight in the previous 6 months or the previous month before referral for first-line therapy, what we found was that more than half of these patients had lost weight with a magnitude of weight loss of 10% their usual weight in the previous 6 months before chemotherapy, and 34% of these patients had lost 6% of their actual weight in the previous month before they started chemotherapy, so even without any effect from the cytotoxic drugs. When we assess these patients using the PGSGA, which is a validated tool to assess nutritional status in cancer patients, what we found was that indeed only 12% of these patients were classified and identified as well-nourished, and the big bunch of patients were indeed moderately or severely malnourished. And when we completed the PGSGA, 84% of these patients pointed with more than 9 points in the score that indicates an urgent need for nutritional intervention. This is another cohort study. This study was conducted in head and neck cancer patients, so the highest nutritional risk cancer patients, I would say. These patients were referred for intense modulation radiotherapy. As you can see, as soon as the patient starts with the treatments of radiotherapy, each one of these lines is the weight of the patients. So these patients, what happens is indeed a very clear decline in their weight as soon as they start being submitted to radiotherapy, and on a weekly basis we register the weight of the patients and the surface area, and this was indeed a cumulative weight loss from the beginning of the radiotherapy until the 6th or 7th week of treatments that these patients were submitted to. And the weight loss in cancer patients has some specificities. One of the major specificity is that it reflects as a selective loss of muscle, and this occurs very early in the diagnosis, or even before the patient knows that he has a cancer, he or she has a cancer. This is a cohort data study from the group of Ryan and Sullivan, and as you can see, very similar to the prevalence of cachexia, the other figure that I've just shown you. What happens is the greater the weight loss, the greater the muscle loss, and this again is very much independent on the primary site of the neoplasm, of the tumor. So this is a cross-sectional characteristic to cancer patients. They selectively lose muscle even before they start losing any other body compartments, and when they start losing weight, this is the first thing that they start losing is muscle. This is another paper that we have published in colorectal cancer patients, metastatic colorectal cancer patients, referred for first-line therapy with chemo and bevacizumab. What we found, and we assessed body composition using the CT scans of the patients, CT scans that were obtained from the patients for staging purposes, for diagnosing purposes. And what we found was that those patients right here in red that had sarcopenia and severe muscle loss, they also had significantly worse overall survival when compared to those patients that did not present muscle loss at the referral for chemotherapy. And we also found a trend for an association between the presence of this muscle loss and a worse ECOG performance status, and a trend for an association with higher systemic inflammation and the greater muscle loss as well. This is another paper that we published last year. This was performed in head and neck cancer patients in a collaborative study with Helsinki University Hospital using the GLIM criteria. The GLIM criteria is the criteria that Aspen has developed, the working group from Aspen has developed in 2022. And using the GLIM criteria, where we assess a constellation of factors, and I will show you the GLIM criteria in a few slides, using a constellation of factors with muscle mass at the center, what we found was that in these patients, malnourished ones had a significantly lower overall survival and also lower disease-free survival when compared to those patients that were not malnourished according to these GLEAM criteria. There are indeed major consequences of malnutrition in cancer. We cannot look around and not see the major complications that malnutrition comes and brings to the patients. Malnutrition is common in this disease. The patients with disease-related malnutrition do have increased toxicity from chemotherapy and from other anti-neoplastic treatments. There is a higher risk of sarcopenia and loss of functionality, reduced quality of life, and increased frailty and increased risk for dependence from other people, reduced tolerance to treatments, higher rate of complications with higher risk of more prolonged hospitalizations with the risks that it brings. So we do know that, and the body of evidence is so robust, is so vast, that pretty much what we need to do is that we need to change this into practice. We need to put all the efforts that we have, and we need to use the methods that the evidence shows us that work to assess and systematically assess and evaluate these patients for muscle mass assessment and nutritional status, so that we effectively and early can referral patients for nutrition. This is one of the methods, very easy one, measuring calf circumference. It gives us an indirect measure of muscle. It has been validated, and it is starting to be used in a wide variety of clinics worldwide. We can also use bioelectric BIA, bioelectrical impedance analysis. This is a scoping review that we published some months ago, testing the effectiveness of using BIA in clinical practice in cancer, and effectively we might be able to use BIA when we do not have other methods, more sophisticated methods for body composition assessment. It is easy to use, does not require much specific training. It's rapid, so it can be an alternative to assess body composition in practice. We do have also the validated tools. We have DEXA, that is very much used in a clinical research mindset, but we have the CT scans at the third lumbar vertebral region, which has been validated for body composition assessment since 2008. So we do have this at our disposal as well, and we are having more and more methods. This is a new software that we are currently validating right now. These images were provided to me by Mirza Faisal, one of the engineers that developed this new software. It assesses body composition of the patients very accurately using multiple slices, and it makes a reconstruction of the body of the patient, and it makes a reconstruction of the infiltration of the muscle with fat tissue, and gives us other outputs just like cardiac measures and other ventral outputs as well. We also have another method for body composition assessment, which is ultrasound. Ultrasound has been very keenly used by ICU physiotherapists. I know this practice for many years now. They were responsible for this integration, and they do it very well. This is the use of ultrasound to assess body composition in a cohort of breast cancer patients. And what the authors found was that they found a very good concordance with the ultrasound parameters and functional muscle function parameters, dynamometry, and other small tests for functionality, and also with in good agreement with the BIA output measures as well. Dynamometry and muscle function is another major goal that it is nowadays recommended by several European groups and by several consensus groups to be integrated in the routine assessment and follow-up of cancer patients, given, for example, by dynamometry, because muscle function and the functionality of the patient gives us a lot of information for us to know our patient, and it does predict survival in a very, very accurate way, as well as the tolerance to treatments. This is another way of measuring muscle functionality. These are very quick function tests that all clinicians can use in their regular routine. I use them myself in my patients, or we can use the dynamometer for hand, or in some institutions, the dynamometer for the leg. And it's very accurate, easy to use, and highly informative to give us the function measures of the patients. So these are the GLIM criteria that I have shown you. So as you can see here, what is in the center of these criteria is indeed the importance of the muscle mass assessment. And how can we do this? We can do this using whatever approach we have in our institution, whether it is a BIA, DEXA, CT scan, or ultrasound. So these are the technical approaches. If we do not have these technical approaches, the GLIM and this decision-making tree helps us on choosing other methods, clinical approaches like anthropometry or physical examination, all this to not let out the information on muscle mass for these patients. We have other initiatives that want to integrate the assessment of weight loss and the assessment of nutritional depletion of the cancer patient in the routine clinical practice. This is the Pronto protocol. This was published in January this year. It includes only 3 questions, very quick questions on weight loss, on functionality, and what usually the patient eats, and if it has any limitation in eating, and very easily it can stratify the patient for early referral for nutrition. This is another screening protocol, but this is for ambulatory patients, so the philosophy is very similar to the Pronto protocol, but it stratifies the patients according to nutritional risk with validated tools, and then according to nutritional risk, we can then safely refer patients for the adequate and the individualized nutrition intervention. What we know is that this sarcopenia and frailty, the major cause of this muscle loss in cancer patients, and this has been focused as well, is indeed the deficient protein intake that characterizes cancer patients. Cancer patients have, many of them have a globally reduced nutritional intake, but specifically and selectively they select protein and they cannot tolerate high protein foods. So it's very typical to find these data in cancer patients, highly deficient protein intake diets with intakes in around 1 gram, 0.7, 0.5 grams per kilogram per day, which is way below the recommended intake that was just updated by ESPEN, and it was confirmed by the ESMO guidelines, as you can see here. This is a systematic review that we published exactly trying to explore the importance of a high protein intake, and what we found by reviewing the literature was that indeed it might be more beneficial to increase and to have a threshold of protein intake more close to 1.5 grams per kilogram per day, so in concordance with the ESPEN recommendation, and less in favor of an intake of 1.2 grams per kilo per day. So indeed, we do need to be more aggressive in terms of protein intake and protein recommendation in these patients. This is a position paper where we focused about the source of protein that was more effective in cancer patients, and what we found by reviewing the literature was that if we are facing curative treatment or palliative treatment, then we should go for protein high and more rich in with more bioavailable value, more rich in essential amino acids, and if we are facing the cancer survivors or if we are on a prevention mindset, then we can focus our attention more to vegetable protein. We also have other nutrients that have been extensively studied. Some of them have been mentioned as well, like fiber. And free fatty acids is one of the major nutrients that has also been included in the ESPEN guidelines as a potential useful and beneficial supplementation that might aid the patient to recover the muscle loss and might aid the patient to prevent from chemotherapy adverse events, just like this scoping review has shown some while ago. So I'm coming to somewhat the end. What I like to think globally when we talk about nutrition in cancer care, and when we talk about early referral, how we should assess, what should we aim for when we assess, I like to think that we should change the way that we look at patients, and we should have our intervention focused on the outcomes of the patients. And for this, I think that we should change our way of acting using more advanced algorithm for integrated care, just like in a similar fashion, just like we have in other areas of medicine, a green wave for stroke or a green wave for sepsis or for myocardial infarction. This is the way that I see it. I think we should have a green wave for nutrition, specifically for the highest risk, highest nutritional risk patients, that they should very quickly and effectively undergo referral for nutrition. So these are the take-home messages. Patients with cancer are more likely to develop malnutrition. Malnutrition does lead to poor health outcomes and early death. Nutritional care should be an integral part of patient care. Patient compliance is absolutely essential, and patients need to be involved in the decision-making process and in the nutrition as well, and develop and implement nutritional strategies, protocols to improve cancer care. This is my last slide. I share with you these pics. These are pics from an old hospital in Italy in 1900s. So as you can see, these are weighing scales. This is a scale with a stool when patients could not stand to be weighed. And these are dynamometers that they already used at this time to assess muscle function of the patient, so very rudimentary. But I actually remember seeing these dynamometers in my hospital some 20 years ago. So it was very nice to see how they already integrated and how they were worried about these parameters and these dimensions of functionality of their patients already in the 1900s. So I think we need to go back, and we really need to pick up on that and now move forward with the evidence that we have. Thank you.
Thank you for your excellent lecture. I'm Tateaki Naito, Cancer Center in Japan, from Cancer Center in Japan. And I'm very interested in that hypothesis that nutritional intervention can improve not only the coexistence with cancer, but also increase the sensitivity to chemotherapy, immunotherapy, or antivascular therapy. And then I want to ask you about what is the most important nutrition for in that purpose to increase the sensitivity to chemotherapy or immunotherapy, which is important, protein, calorie, or other specific nutrients such as EPA or BCAA. What do you think about it?
You want to start? Go.
Yeah. That's a pertinent question. I think that we all think that nutrition as a whole should be complete, but we do know that we do have specific roles for specific nutrients. Protein is definitely a priority, and 3 fatty acids have been demonstrated to aid as adjuvant agent for some agents of chemotherapy and of immunotherapy as well. And we are having some very recent data on the importance of the modulation of the microbiota with fibers and probiotics and prebiotics, and the treatment of melanoma, for instance, with immunotherapy. So I would say that these 3 are very robust in data and in results, and I think that you could start there using this priority. Yeah.
Thank you so much.
Thank you for your question.
I will just complete by saying, of course, I agree with you. This is very important to use this specific micronutrient, but the first, I'd say, thing to check if your patient is receiving enough calories and protein. And then, of course, you need to use what is evidence-based on other micronutrients. But sometimes we not check enough if patient is receiving enough calorie and proteins.
Yeah, thank you very much for your presentation. My name is Dr. Ogochukwu. I'm a hematologist from Nigeria. what I would like to point out is, from your talks on malnutrition.
Sorry, could you please close the door? There's a lot of noise and I'm struggling to
Yes,
listen.
okay, so let me speak up. From your talk on malnutrition, I can see that the major focus is on undernutrition. And you didn't make even maybe some small talks on overnutrition. Mm-hmm. I did a study with breast cancer patients. That was during my residency days. It's a published paper. And one of the things I found out about them was they tend to eat a lot. Mm-hmm. Yes, and from the study, we found out that their daily caloric intake was more than their total energy expenditure. Yeah. Of course, we didn't look at certain confounders because we only look at their dietary intake. The drugs they were using and other supplements we didn't try to check. So, and of course, we did find out that they have quite a large body fat percentage. So, one of the things we came out from it was these people will need a nutrition program just as much as people that have undernutrition, so as to guide them in eating better. So what I would just like to ask is, are there guidelines for overnutrition in that regards? Thank you.
I wouldn't call that actually overnutrition, because I think that overnutrition is a different concept, but I understand what you mean. Breast cancer patients is a totally different reality, just like prostate cancer patients. And the data do show that breast cancer patients do have peaks of intake, and they tend to have also overweight and excess body weight, excess adiposity, also associated with high caloric intake. Very interestingly, I have reviewed some papers around a month ago for another conference where I was for breast cancer patients, and there are 3 randomized controlled trials undergoing exactly to try to cope with that a change for breast cancer patients, which is the patients not exercising enough, not eating well. So there are underway recruiting patients for an adequate diet, for a healthy lifestyle, physical activity, to try to counteract that overnutrition that you mentioned, because it is a major prognostic factor for the patients per se. So it is something that it has to be dealt with, but it is totally different from the major nutritional concerns that we are talking here. I would say much more overnutrition in your specialty, in hematology, for instance, or not overnutrition per se, but overload. We have very recently, 2 weeks ago, we are going to submit a new data for the ASPEN Congress, assessing body composition in hematology cancer patients, because we do not have a lot of data in that specialty. And what we found was that body composition assessment might be tricky in those patients, exactly because of the load that those patients are given when they are in the hospital. So just, yeah, those are different. It is a different reality as well. Hemato-oncology is a different reality as well for solid tumors. So thank you for your question.
Thank you very much. We need to leave the room. Thank you again, and I hope to see you all soon.